Good evening, everybody, and welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Baljinder Dhinsa from the United Kingdom. Dr. Dhinsa is a fellowship-trained consultant orthopedic surgeon specializing in the treatment of foot and ankle conditions. He currently works in Kent as well as in London in the United Kingdom. After his undergraduate degree from the Guy's, King's and St. Thomas Medical School, he completed trauma and orthopedic higher surgical training on the Southeast Chains rotation. During this training, he held the role of the academy doctor at the Charlton Athletic Football Club, which provided him the experience of managing sports players. To further his foot and ankle training and to learn advanced techniques in foot and ankle surgery, he completed British Orthopaedic Foot and Ankle Surgery, the BOFA's approved fellowship at the Guy's and St. Thomas Hospital, as well as in Malawi. He's also taken part in a visiting fellowship with Professor Hintermann in Basel, Switzerland. If you've noticed, Dr. Dhinsa has delivered a lecture on a channel in the past, and which has already reached a huge audience. And today it's my great honor to bring back Dr. Baljinder Dhinsa for this wonderful live program. Over to you, Bal.
Thank you, Tesh, and thank you for the opportunity to talk again. As last time, I'm more than happy if there's any questions that I can't answer today for you to email via Mr. Goplan, and I'm happy to reply by email as well. So today's talk is going to be on Hallux Rigidus. So Hallux Rigidus was first described in 1887 and is described as a painful condition of the metatarsal phalangeal joint of the great toe, and is characterized by a restricted range of motion, predominantly dorsiflexion, and it's got proliferative periarticular bone formation as well associated with it. There's other names that have been interlinked with it, including Hallux limitus, a dorsal bunion, or metatarsal primus elevatus, to just name a few. But rigidus seems to be the name that sticks with it, and it makes more sense, as limitus is more to do with restricted specific movements, where rigidus describes the full range. So this is the most common arthritic condition in the foot. And Nielsen did try to break it down into adolescent and adult type. Adolescents being predominantly associated with, as the name suggests, younger people and with an osteochondral defect. And the adult type is more likely to be secondary as a result of degenerative joint changes. However, it's felt that there was no need for this divide and description later on. However, some people still keep to it. Some studies have also suggested that there's a 50% incidence of family history associated with people developing Hallux rigidus in their adolescence. And a study in a case series by Coughlin showed that nearly 95% of patients with a positive family history of great toe problems had bilateral Hallux rigidus. They also demonstrated that 80% of all patients with Hallux rigidus had a positive family history. So it's slightly different to just your classical degenerative joint disease, and there seems to be a clear genetic component to this. The etiology remains unclear. It's been postulated that it's due to trauma, whether this is acute, and this is generally from hyperextension or hyperplantar flexion. And this results in impaction of the base of the proximal phalanx on the metatarsal head and leads to some cartilage damage, or it may be due to repetitive microtrauma. And this once again results in chondral damage. It's also been postulated, but there's no evidence of relation that it may be related to congenital flattened or squared metatarsal head, either elongated or shortened first metatarsals, tight intrinsic muscles, pes planus or hindfoot pronation, or congruent metatarsal phalangeal joint of the hallux. But once again, I reiterate that this hasn't been proven, any of these associations. So what do patients describe in the history? There's classically pain and swelling in the early phases and in the development of stiffness. As this progresses, they often develop a restricted dorsiflexion, and this is what they complain about, pain with movement. And it's particularly, as I say, with dorsiflexion, but it can happen with plantar flexion. As the disease progresses and they develop changes with hypertrophy of the dorsal bone, you'd get a dorsal prominence, which you can see in this picture. And this is often when they present, because this is where they're having restriction in their footwear. And this is due to the pressure effect of a closed-in toe box. And you get the friction effect due to the shoes rubbing on this prominence. And as this progresses, you may also get altered sensation. And this is due to the dorsal nerve impinging on this prominence and getting compressed within the toe box as well. It may be that patients don't really present at this stage. It may be secondary to a hallux rigidus that develops due to degenerative changes, and this has been associated with it as well as other soft tissue changes. And it may lead to transfer metatarsalgia as well. On examination, once again, as with all examinations in the FRCS exam, unless directed by the examiner to look specifically at the hallux, you should start off with looking at the patient's gait, asking them to take their shoes off, assessing the shoes, looking for any orthotics, the wear pattern, and then you look at the alignment of the foot, and then you go to the look, feel, move for the rest of the alignment of the hind foot, midfoot, and forefoot. In the early stages of the disease, they typically have just synovial thickening, but as this progresses, once again, you develop the bony hypertrophy and osteophyte formation. And you can often feel this as a keyless or osteophyte forming on dorsally. And more commonly, it happens on the dorsal lateral aspect first. They often have limitations in their range of motion, as I mentioned, and particularly with dorsiflexion, it tends to be a bony impingement of the proximal phalanx rubbing against the dorsal aspect of the metatarsal head, and also the osteophytes that are forming. With plantar flexion, you get the pain due to stretching of the capsule, as well as the extensor hallucis longus, and this can cause significant irritation. And also you get the nerve type irritation I mentioned earlier, and this can demonstrate itself as tingling or hyperesthesia, and it may also demonstrate a Tinel's positive type sign to the dorsal nerve. Once again, on the examination, when you finish, you should also check for peripheral pulses to rule out any other causes, and you should also look at sensation as well, not just subjective, but to light touch. Now, imaging, the basic imaging you should always get is weight-bearing AP lateral medial oblique views. And if these are all normal and it's in the adolescent, it'd be sensible to get an MRI scan to look at for an osteochondral defect. Now, on the lateral views in significant progressed disease, you'll see the dorsal osteophytes or traction type and physiopathy type spur. And they often describe this as like candle wax, as it goes from distal to proximal. On oblique view is often important to get because in the early stages, the AP view may be obstructed by the spur and you may not be able to see the joint clearly. However, in the oblique view, you may demonstrate that there's an adequate joint space and it's purely a dorsal spur that's causing the view to look like it's a progressive disease. As I mentioned, on the AP view, you often have the spur formation and osteophytes more on the lateral aspect first than the medial aspect. The typical findings you see on the AP view, in the early stages, you get the non-uniform joint space narrowing. You may get some early spur formation, but certainly in advanced stages, as you can see here, you get the subchondral cyst, you get the sclerosis, you get the widening of the base of the proximal phalanx, which is typical of degenerative joint disease. It's in the early stages where it's difficult to identify, and this is when you're relying more on the symptoms, the history, and as I said, you may want to get an MRI scan to assess for the cartilage damage and osteochondral defects, because this will help delineate this. As things progress, you may also find some loose bodies from where the osteophytes have been broken, and this often leads to significant pain and bruising when osteophytes fracture off as well. And so this is something that needs to be have a low threshold for assessment on the examination. Regards to CT scan, I don't think there's much role for a CT scan with this because you can see most things on the plain films, and if it's chondral, is going to be better to be seen on the MRI scan. And certainly, I don't think there's any role for ultrasound unless you're worried about suspicion of a ganglion. And once again, this would be seen on the MRI scan. And also, there's no role for bone scans at this stage. Now, as you know, with most orthopedic conditions, there's always a need for staging. And this is the proposed staging for the condition. As you see, it goes from grade 0 to 4, and it looks at the range of motion, and also dorsiflexion and plantar flexion. And as you go through the stages, the restriction increases. Radiographically is looking at dorsal osteophytes and joint space narrowing. And clinically is more about the range of motion and stiffness. So initially it's more pain, and then progressively becomes more stiffness that becomes the issue. And this is what helps us determine as well as discussing with the patient about how to best manage them. And it's important to have a look at all these factors before we discuss with the patient options and management, as this can be easily misled based on just one of these factors. You need to look at all three factors. And as we mentioned, it is a predominantly progresses to a degenerative joint disease. It may start off with osteochondral defect, but often when we see them, it has developed a degenerative joint disease. And so it's worthwhile for the exam just to look at the basic pathophysiology and the reasons for this. We know this is a disease that's characterized by an inherent defect in the chondrocytes and the cartilage matrix that this produces. We know in the early stages, there's a proliferation of chondrocytes. They're multiplying in number, and these produce interleukin-1 and tumor necrosis factors. This inhibits the formation of proteoglycans and type 2 collagen, and this in turn leads to degeneration and thinning of the cartilage layer. With the inflammatory cascade beginning, the water content within the cartilage layer increases, and subsequently you also get the concentration of proteoglycans decreases. This has a gross effect on making the cartilage soft and friable, and it begins to fissure. And it's at this stage that the soft cartilage surface shows cracks and thinning, and the synovium becomes fibrotic and hyperemic, and you get a chronic inflammatory cell infiltration. Now, with repetitive mechanical trauma, you can get fragmentation of the articular cartilage, and this can break off, and this is where you start developing the pain and discomfort because you get exposed subchondral bone with eburnated bone surfaces. And as this progresses, you can develop crevices, which allow synovial fluid to penetrate the surface. And this is where you get the subchondral cysts, which we mentioned on the previous slide. Now, how do we manage this? Well, as with all things, we should always give a trial and non-operative management. And certainly, I think a period of 6 months is sensible, if not up to a year, depending on how the patients cope and depending on where they are on their pathway. And depends how severe their symptoms are as well. Simple measures are wearing wider, taller toe boxes, wider fitting shoes to make it more comfortable. Having a stiff-soled shoe is good because it reduces the range of motion and this reduces the symptoms. You can consider having a carbon fiber foot plate with a Morton's extension to once again reduce the metatarsophalangeal joint motion, and this helps with their symptoms. There is a suggestion for a role of injections, and you could do a steroid injection, which will help with that anti-inflammatory response, as well as giving some short-term symptom relief. And prior to this, you can also consider non-steroidal anti-inflammatories to see if this will help as well as non-steroidal gels. There's been a suggestion that there's a role for Synvis type injections, which are like hyaluronic acid injections. This can certainly help to increase the layer between the joint surfaces, but there's no evidence as of yet that this has benefit for Hallux rigidus. Certainly, steroid injection can give relief reported for up to 6 months, but once again, it determines at the level of the disease, and certainly be limited in advanced disease when there's significant exostosis. But certainly, it's worthwhile considering in the early stages. I think the best thing, if the patients tolerate it, are the wider fitting shoes and the stiff-soled shoes, as this really helps settle their movements and control their symptoms. And now we move on to surgical options. And this is, as I said, if they've exhausted non-operative measures, and this is at least trying it for at least 6 months at a minimum, and then you can consider the surgical interventions. I'm going to go through these step by step. I think certainly in grades 1 to 2, maybe some grade 3s, you can consider open colectomy. And this essentially involves removing the dorsal third of the metatarsal head, removing osteophytes with this, as well as taking off osteophytes from the base of the proximal phalanx. And this was first described by Duvries in 1959, and this has shown good results in relieving their symptoms. It's important that this is a pain-relieving measure, and it's not necessarily going to improve their range of motion. And certainly you can be misguided, because on table you may get a range of motion of dorsiflexion to 80 to 90 degrees, but in real life this is only going to really achieve up to 40 degrees at a maximum. But really it does help with improving their pain levels, and this is where it gets the benefit. In a study by Coughlin, it's shown a 97% satisfaction rate regards to pain relief, and this was an average of a 9-year follow-up, so fairly long-term results. Other studies, which slightly less follow-up, have shown upwards of 90% of satisfaction, and it's showing good results regards to medium to long term. The need for conversion to arthrodesis, particularly in the early stages, is low, and it's been less than 10%. But certainly in the advanced stages, the need for revision is higher, and therefore you really need to consider whether we should be doing this in the more advanced stages, as it has limited benefit. The benefit of the procedure is day case. They're able to weight bear straight away, and once the wound's healed, they're out of their dressings and allowed to get back to activities without any real restriction. Now we look at more of the joint preserving but mechanical changing procedures. Moberg osteotomy, which was originally described in 1952, had some promising results. And this is a dorsiflexion osteotomy of the proximal phalanx, and it was modified at some stage to also include a colectomy as well. And this essentially is an osteotomy which relies on the dorsal 1/3 disease cartilage, and therefore will help resolve the symptoms. Its benefits were mainly in the grade 1 to 2 Hallux Rigidus, and a study by Thomas and Smith showed a 99% satisfaction rate without any major need for revision surgery or complications. O'Malley also did a study on grade 3, and the satisfaction rate was slightly less at 85%, but once again, there was only four patients, which was 4.9% of patients required a conversion to arthrodesis. So once again, the results were good. The problem with this now was that despite the good long-term results, the conversion to arthrodesis was complicated, and this is because of the position of the proximal phalanx. This made it difficult when doing arthrodesis to get the toe position the correct way, and this is why it sort of lost flavour with a lot of surgeons. The Keller resection arthroplasty was also described, and this is essentially a resection of the base of the proximal phalanx, and it often involved taking out the insertion of the flexor hallucis brevis. This obviously was related to some complications, and so some modifications have been included where we try to maintain some of the insertion of FHB to try to prevent the complications we're going to mention shortly. This once again demonstrated good pain relief, improved range of motion, but it had an effect of creating reduced power of toe off, metatarsalgia, and a cock-up deformity. It made a series done by Love et al. Showed satisfaction rate and pain relief in 91% of patients and satisfaction of 77%. But the biggest problem was that 40% of patients had a cock-up deformity. And once again, this is why it lost favour. There was a modification to an interpositional arthroplasty. This essentially was limited Keller's resection and then a placement of a biological spacer within the joint to try and prevent the cock-up deformity. And this would either be a capsule, which was advanced, or it could be a muscle, or even some tendon. And this was to try to prevent the complications of the Keller procedure. However, the patient still developed hallux weakness and transfer metatarsalgia. So once again, this started to lose favour. Once again, it showed initial short-term good results, but there was the long-term results weren't quite there. And then we move on to metatarsophalangeal joint arthroplasty. Now, this initially was predominantly celastic implants, and then it moved on to all metal implants, then ceramic implants, and now we've moved on to synthetic cartilage implants. The problem with the celastic implants were the first and second generations developed a lot of osteolysis, they developed an immune reaction, and then also implant subsidence. And whilst they had good short-term satisfaction rates, the medium to long-term results weren't as good, and there was a significant number that needed converted to arthrodesis, and this was associated with significant difficulties due to a loss of bone stock as well. Certainly, the newer generations are proving some benefit, but once again, these are the ones in patients that are more sedentary, less active, and slightly older, and typically the inflammatory type patients, and they tend to do well with this. Then we moved on to the metal implants, and these initially tried to replicate the total hip and total knee implants with a cobalt chrome metatarsal prosthesis with a polyethylene insert and a titanium proximal phalanx prosthesis. And whilst there was initial good results with regards to satisfaction and range of motion and pain scores, this unfortunately had the same problems with the celastic implants in the fact they had osteolysis and implant subsidence. And they then suggested trying to use ceramic, but once again, this was plagued by the same problems and the high conversion rate to arthrodesis due to their subsidence and implant failure. And certainly there was a high rate of reoperation rate. We then moved on to the hemi-arthroplasties, where we replaced the metatarsal head with a contoured articular prosthesis. And this is showing some initial promising results with satisfaction rates as well as pain score. However, the revision rate is still, in the last paper, about 13% at 5 years. And the problem with this, once again, is with conversion to arthrodesis, there's a lot of bone stock loss. And if there's subsidence as well, this is causing the revision surgery to be quite complicated. And therefore, slowly, people are moving away from this hemi-arthroplasty. And then we have the synthetic implants. And I think Cartiva is the biggest implant that we use worldwide at the moment for this. And this involves synthetic cartilage implant. And where the defect is within the metatarsal head, you use a drill to take about 8 to 10 millimeters around, and you create a little hole there for this implant to be placed. And this works as a type of spacer, but it allows movement and improved pain scores as well. And Baumhauer et al. Did a multi-center study, and it certainly showed at 2 years good results with pain scores and patient satisfaction. And there was an average improvement at 4 degrees of dorsiflexion. However, the revision rate was about 9%. And certainly there's been other papers which have suggested a higher rate of revision. And we have to take this into account about whether this was wrong patient selection and whether they had advanced disease and therefore there wasn't the right patient for this. And or whether this is true and that if it's not been done by the designers, that the success rate is slightly less. And so we're still awaiting the long-term results of this, as the latest data is only up to 2 years. And certainly the benefit of it is that when it does need a revision, due to the less bone stock being taken for this primary surgery, the revision is certainly a lot easier and makes it a lot more easy to perform, to do an arthrodesis, which may be needed at some point. On the other side, in order to do a Cartiva, you need to have adequate bone stock in the initial setting, and you need at least 2 millimeters around the prepared area for it to be adequate placement. And if you don't have this, it's a contraindication to doing this type of procedure. And then we move on to the gold standard, which is the Hallux metatarsal joint arthrodesis. And this has been shown to have good results consistently in literature. And it's predominantly in a progressive disease. So you're looking at grade 3 onwards. It's showing good results, particularly when it's got concomitant conditions such as rheumatoid arthritis, Hallux valgus. It allows correction for all of this. And also in patients with neuromuscular disorders. And therefore, it has the benefit of dealing with all of that with one procedure. And it provides a consistent result, and it's more predictable. And you're less reliant on the soft tissues to protect your correction. Now, the optimal position is debatable and it's patient specific. Certainly, if you're doing it in a person that wants to wear high heels, you'd have to have slightly more dorsiflexion. And if you've got someone that doesn't want to wear high heels, you can place this in the more predictable and optimal position, which is about 10 to 15 degrees of dorsiflexion relative to the floor. Certainly, if you're doing it relative to the axis of the metatarsal, it should be slightly higher, and it should be 20 to 25 degrees. You want slump valgus, about 5 to 15 degrees of valgus. And certainly you want to allow this so that the toe can have the toe off appropriately so that you don't affect the function of the toe. And one way to assess this is to have a foot plate. So when you're positioning the toe, the tip of the toe should ideally be sitting on the foot plate, and you should be able to get your finger underneath the toe and be able to lift it up slightly. And this will certainly prevent having problems in your interphalangeal joint as well, and by having it excessively plantarflexed or dorsiflexed. The problem with having it excessively dorsiflexed as well is that it can have issues in getting your foot into appropriate footwear. Now, preparing the joint can be done in several ways. You can use it with conical reamers, which provides a nice surface to allow you to correct the position of the toe, and it allows concentric reduction, which helps with positioning of the toe. However, conical reamers have been associated with a slightly higher rate of non-union, which may be a result of the thermal necrosis from this, but I'm not sure. And there's no evidence or explanation for why this is seen, but it has been seen. Another way of doing it is preparing the surfaces with a nibbler and trying to maintain the cup and cone type position. And this is slightly more labor intensive, but gives you slightly more control. And another way is with flat cuts. And certainly with flat cuts makes the reduction and positioning slightly more difficult. It does make it slightly quicker, but certainly the reduction is slightly more difficult with this and getting the position correct. But it does allow for correction of deformities, because you can place the foot in more valgus varus or plantar or dorsal position, depending on whether there's any defects within the bone and malalignment beforehand. And how do we fix the toe in its fused position? Well, once again, there's several ways of doing this. You can do cross screws, which can be done in a lag screw technique. You can do a lag screw and this neutralization plate dorsally, or you can do a lag screw as well as a locking compression plate, so you get two modes of compression. There's also been a move to using staples as well, compression staples, where you can do a minimum of 2 and 90 degrees to each other, or some people can do three staples to hold this in position. Certainly biomechanically, the best construct has been shown to be the lag screw with a dorsal plate, whether it's locking or non-locking, or whether that's a compression mode. And certainly the plates allow some help with positioning of the toe, because there's a certain degree of dorsiflexion already embedded in the plate, so it can help with positioning. The problem with this is the increase in costs compared to 2 cross screws. And certainly, in regards to union rates, there's no significant difference in the literature in regards to the different constructs, in regards to union rate. Now, just looking at some literature in regards to this, Gatchler and Coughlin looked at lag screw and plate construct, and they had 96% satisfaction rate and 4% revision rate. Bennett and Sabetta looked at dorsal plate alone and had 99% union and 1% revision rate. And interestingly, Brodsky et al. Looked at the function of the patient, because this is often something that is put by patients, that the arthrodesis will affect their ability to do their function, not just normal weight bearing, but work as well as activities. And this is an important factor to consider. And this is part of education during your consultation as well. And the Brodsky et al. Showed 92% of patients returned to hiking, 80% returned to golf, 75% returned to tennis, and 75% also returned to jogging. And this is very interesting, and it's interesting information to give to the patient as well. And Dufresne et al. Actually looked at a gait analysis, and they showed that with metatarsal joint arthrodesis in the optimal position, there's restoration of weight bearing to the first ray. So certainly this is all encouraging, and certainly explains why this is the gold standard procedure. But certainly the other options also provide some benefit, and it's a matter of discussing the pros and cons with the patient, as well as looking at the deformity, the radiology, as well as the patient's expectations before you decide which one to go with. Now, I mentioned earlier that it's patient specific. This is an example of a dancer who did ballet dance and was teaching, and she wanted to be able to go on this position. And this is a post-op X-ray, post-op picture. And certainly you can see she's been able to get back to the position she wants to be able to do her activity. And this is by slightly dorsiflexing your toe a bit more. And this is done with counselling with the patient and explaining why we were doing this to help with her function. Okay, thank you.
Thank you, Bal, for yet another brilliant talk from your side. Bal, a couple of questions.
Yeah.
Is there any role for a wild kind of osteotomy, especially if there's a long first metatarsal?
There has been some talk of that, but I think it's hard to control the rotation as well as the alignment with just the vials. Some people have suggested it with a little colectomy as well and taking some of the proximal phalanx. But once again, it's very difficult to control it. I think you get better reliable reduction of the length of the metatarsal for a fusion rather than doing that. But certainly you could consider that, and it could be as part of a Keller's type procedure as well to try and reduce it.
Thank you, Bal, for that. And what do you think is the role for an MTP joint arthroscopy? For example, in the US, a lot of foot and ankle surgeons are gradually going into first metatarsal joint arthroscopy. Do you think there's a role for a very early disease, for example, arthroscopic debridement and excision of the osteophytes, etc.?
Yeah, no, just going back quickly, Hitesh, to you mentioned the metatarsal length. When there's a brachymetatarsa, there is a role for doing lengthening, if that is to help, because there is a short metatarsal that can cause this. And some people are advocating putting an inline frame to lengthen the metatarsal as well. And there is early evidence just that may help, but obviously that's quite complicated with the soft tissues, but that is an option to lengthen. Now, with regards to arthroscopy that you just asked us now, there is a role for soft tissue assessment with an arthroscope to debride it. The problem with that is you need the potential to open, if there is an osteochondral defect, to do a microfracture as well at the same time. And certainly, as long as the patient is consented for that, that might be worthwhile doing at the same sitting. But I don't think it's purely arthroscopic, because if there is an osteochondral defect, you have to open to do the microfracture. Yeah, I think regards to removing the spurs, it's very hard to do that arthroscopically. You can do it MIS with a little incision and using a burr, but arthroscopically, it's very hard to get rid of the spurs. It's more for the osteochondral defect you can do the scope.
And what is the trend among foot and ankle surgeons in the UK regarding an MTP joint arthroscopy because of the availability of very small scopes, the nanoscopes, etc.?
Yeah, it's something, it's not even with the nanoscope. We used to use the wrist scopes, and I used to do it on my fellowship, and that is something that has been done. The problem with the scopes are the actual outcome, and subjectively, I've got no literature on it, but subjectively, the patients don't get that much benefit. They still struggle with the pain afterwards, and that's why subjectively we're moving away from it. I think it's in a very young patient, and it's early stage. I think it's worthwhile, and I think with the nanoscope, it's becoming more and more a feasible option. Because with the wrist scope, we're still quite big. With the nanoscope, it's much smaller. And certainly that is something we consider. But once again, it'd be a stage 0 to stage 1. I think once you get into stage 2, I think it has limited benefit.
Thank you, Bal, for that. And just one last question before we wind up the session. What has been the workhorse procedure in your practice? For example, I know it depends on different stages of the disease, but what is the procedure that you do very commonly? Yeah,
so my most common procedure is arthrodesis. And that's normally because I'm seeing the patients at stage 3, 4, and they want an answer. They tend to be quite young. They tend to be around the 40s, 50s. They're active, they're working, and they want to get back to work. And so I find that to be a consistent, predictable procedure. I can promise them that most of them will get back to work and they're comfortable. In the slightly older patients, I do scholastic implants. I have done scholastic implants, and I do them. We get okay results to them, but I'm always wary, and I do counsel the patients about the risk of osteolysis and an immune reaction. You get this sort of inflammation around the joint, and they're aware of that, and they opt for that over an arthrodesis. Certainly stage 1, I always do a colectomy. I haven't done the synthetic cartilage implant just because I'm waiting for long-term data yet, and we still haven't got the data for that. I like to have at least 10 years data before I consider doing something.
Thank you, Bal. I think that's all the questions that we have for this session. Fantastic lecture, and I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in, Bal.
Thank you. Pleasure.
Bye-bye.